aortic stenosis is the term used when the aortic wall becomes narrow. The aortic wall, its normal role is closing. It opens during systole and endothelium is closed. So it prevents backflow from the aorta to the left ventricle. From the left ventricle, aorta arises, main artery, and the blood flows into the rest of the body. This is the main single vessel. Base of it is aortic wall. The three valves are there, tricuspid wall. This tricuspid wall closes, and this prevents any backflow during diastole. It opens during systole, closes during diastole. Now, aortic stenosis, the wall has to open during systole and coact during diastole. That's the term used. Perfect coaptation. Perfect. One should be aligned to the other. There are three. There are not two. There are three. 1, 2, and 3. Get aligned perfectly. That is coaptation of the wall. And this happens during diastole. That's the role of aortic wall. In aortic stenosis, the valves do not open fully for various reasons. The reasons vary depending on the type of the cause and type of the valve. If you go by the cause, what are the causes of aortic stenosis? Important cause for us, rheumatic. Then it could be bicuspid aortic wall. If someone asks you what is the commonest congenital lesion seen in the heart, it is the bicuspid aortic wall. About 2% people have it. Runs in families and has a habit of being clustered. One family, many members have it. So clustering is a phenomenon seen in aortic bicuspid aortic wall. So at rheumatic, bicuspid aortic wall, calcific aortic stenosis. Then degenerative aortic stenosis. Degenerative aortic stenosis is one where the aortic wall is narrow because of degenerative changes. One of the degenerative changes is manipal sclerosis. One more is aortic sclerosis, aortic circular sclerosis. So these walls can get narrow, whatever reason, less blood will flow across. If the wall is a tricuspid wall, the common causes are rheumatic and degenerative. If it is a bicuspid wall, common cause is calcification of the bicuspid wall and thickening of the bicuspid wall. If it is a monocuspid wall, sometimes there is only one cusp. The cause of a monocuspid wall producing stenosis is congenital monocuspid wall, which is seen in very young age, infancy and young age. Whatever be the cause, what happens to the patient, what is the pathophysiology of aortic stenosis? We recapitulate, blood comes from superior inferior vena cava into the right atrium, from there goes to right ventricle, from there it goes to pulmonary artery, lungs, from there the lungs, it goes, purified blood goes to the left atrium to the pulmonary vein, from there to the left ventricle. All this happens normally. From the left ventricle, once it goes out in the aorta, to be circulated to the rest of the body. Therein lies the problem. So where is the problem in aortic stenosis? For the blood to go out into the aorta. This is a mandatory requirement. It has to go into aorta, from aorta to the remaining body. That aorta to the ventricle, left ventricle to aorta, there is narrowing of the valve, so it doesn't freely flow. When the blood doesn't freely flow from left ventricle to aorta, what happens? Nature doesn't keep quiet. It produces certain compensatory changes. What are the compensatory changes that take place in the left ventricle? There is going to be increased pressure generation. Now this is governed by a law called as Laplace's law, physics. If you have thought in physics as W, it will come behind you. In ophthalmology, medicine, many topics, you need physics. So, Laplace's law, according to which the pressure generated depends on the pressure and the radius of the valve and the thickness of the ventricle. So these factors, the pressure, the thickness of the ventricle, and radius of the valve. Radius of the valve. So this multiplied by this left ventricular pressure radius divided by thickness of the ventricle. This is known as Laplace law. This decides how much pressure is generated. And more pressure generation, better flow. This is a compensatory mechanism. This is a successful compensatory mechanism. Okay. Because this has been, patient will be asymptomatic for a long time. Patient will be asymptomatic for a long time. Patient will not have symptoms. So this makes the patient asymptomatic, compensate. So what is the outcome of this? The outcome of this Laplace law in aortic stenosis, to mention in one word, is LVH. What happens? There is left ventricular hypertrophy. So we shall derive the pathophysiology from the left ventricle. Blood has to go to aorta. Because of this difficulty here, aortic wall narrowing, there is difficulty for blood to go, so the left ventricle has to exert more pressure and undergo hypertrophy. Why did I draw concentric line? It is concentric hypertrophy. It is concentric hypertrophy. So what happens to left ventricle? There is LVH. Because of LVH, what happens? Initially there is compensation. Nothing happens. Asymptomatic. What is the initial picture of a patient with aortic stenosis for a fairly long time? Asymptomatic. Then what happens? Then the problem comes. For any increase in the size, proportionate increase in blood supply is needed. For a while it happens, then it doesn't happen. And what is the difference? The pressure, the size of the muscle is more, size of the blood is less, the amount of blood is less, so there will be disturbance giving rise to coronary insufficiency. So what is one change that takes place in due to LVH? There is angina. What is one change? Angina. What is the change for a long time? Asymptomatic. What is the feature that happens? Later, they become symptomatic. What are the symptoms? Angina. Then this becomes a hypertrophy. For a long time, potentially there will be arrhythmia. And LVH. So what are the three adverse effects of a left ventricular hypertrophy? When it's not known the left ventricular hypertrophy, any cause, the same answer. Left ventricular hypertrophy gives rise to three adverse effects. One, angina. Why? Increasing thickness of the muscle, less blood supply, relatively less increase in blood supply. In addition, two, the muscle fiber can lengthen, it becomes thicker, stronger, longer. Initial length of muscle fiber increases, this compensates. After stage comes within physiological limits, which is full. The physiological limits are exceeded, they go into left ventricular failure. Three, because of this, there is a potential arrhythmia. So they can go into ventricular tachycardia, ventricular ectopic, ventricular tachycardia, and sudden death. So, what are the features that can come related to arrhythmia? Ventricular ectopic or premature ventricular contraction, ventricular tachycardia, and sudden death. Now, there is LVH. So, where will be the effect? It will be down and out, 6 space, 7 space. What will be the type of effect? Because the concentric hypertrophy, it is heaving effect. What are the features of heaving effect? It is well localized, well sustained, forceful. What are the two conditions that give a heaving effect? Aortic stenosis, hypertension. So LVH, three features: angina, non-exertion initially, LVH after a while, and because of LVH, what is the feature? We discussed it in detail under MS. You have pulmonary capillary, pulmonary capillary, pulmonary artery. One thing in common, they have dyspnea. They have restlessness. So what is the feature? So if somebody asks you, and what happens when there is arrhythmia? What is the other outcome of arrhythmia? Syncope. So what are the three symptoms which come in aortic stenosis? Which are the bad symptoms, bad omen? Most of the time asymptomatic. They become symptomatic three symptoms. What are the three symptoms? Dyspnea, syncope, angina. These are the three symptoms. This is how we derive the symptoms. What are the symptoms? Dyspnea, angina, syncope. Why dyspnea? Because there will be or pulmonary venous pressure increase, pulmonary capillary pressure increase, spinal elevation. Why angina? Discrepancy in muscle hypertrophy and blood supply. Why arrhythmia? What arrhythmia? There could be vertical ectopic, pre-attack, sudden death. What is the outcome of arrhythmia? Syncope. Why syncope? Arrhythmia or decreased cardiac output, hypotension. These are the two causes of arrhythmia. So these are the clinical features. How to derive the clinical features of aortic stenosis. Now we trace this backwards. What happens in left ventricular system? What happens in left atrium? Left atrium enlarged. Then the pulmonary capillary is affected. Pulmonary veins are affected. Pulmonary capillary is affected. Pulmonary artery comes to right ventricle. There are two mechanisms for the right ventricle to inward. One is the long route. One, there is increased blood in the left ventricle because it's not going forward, so difficult to go forward. And it pushes the interventricular septum into the right ventricle. This is known as the birth time effect. So there are two reasons why the right ventricular load increases. One, birth time effect. That is, increases the volume of blood in the left ventricle. Interventricular septum bulges towards the right ventricle because of the extra load. So there is an increase in the capacity, so relative increase in the volume of right ventricle, giving rise to a situation of inadequate space, and therefore this is going to right ventricular phenomenon like right ventricular hypertrophy, long way. And the second mechanism, which is the standard mechanism, is back pressure, left atrium, right pulmonary, capillary, pulmonary vein, pulmonary capillary, pulmonary artery, and then right ventricular hypertrophy. That is the same as all valvular lesions. Now coming to the clinical features. What are the clinical features of this situation? General examination and history, general examination and examination of serious. Mitral stenosis and incompetence predominantly had cardiac. Aortic has two sets of things, peripheral and central. So what are the features of aortic stenosis? It could be asymptomatic or it could be symptomatic. So many times, for a long time, asymptomatic. It could be symptomatic, dyspnea, angina, syncope. The symptoms, general examination, pulse. What is the type of pulse? Cardiac output is low, and the rise in which the speed at which the volume rises is slow. With a low volume, slow rising pulse known as pulsus parvus retardus. Pulsus parvus retardus. Cardiac is a slow rising with a low volume pulse. Low volume, slow rising pulse, parvus retardus, low volume. Blood pressure, the systolic is low. Classical blood pressure of aortic stenosis is something like low blood pressure, low systolic. Because of this, they can have hypotension, they can have postural hypotension, they can have syncopal attack, they can have intermittent claudication, they can have angina, they can have another low syncope, angina, postural hypertension, fatigue. They can have fatigue. Fatigue is an important feature of aortic valve because of low blood pressure. They can have fatigue, syncope, angina, examination of the serious proper. On inspection, you may have effect which let us say down and out, or down stairs. On palpation, the heaving area. And wherever you see the effect, well felt. On auscultation, this is the most important part. You take the auscultation, the first sound, the second sound, aortic, the second sound, pulmonary, the next first sound. You have to learn yourself. In my stenosis, we are talking reverse, we are talking of diastasis, we are talking of systolic. Okay. So now, what happens in aortic stenosis? This is the first sound. This is the second sound. This will you have to watch carefully. This is the aortic component of the second sound. This is the pulmonary component of the second sound. Normally, the first sound is produced by simultaneous synchronous closure of mitral and tricuspid valves, the valvular sound. Second sound is produced by the synchronous closure of aortic and pulmonary valves. I have drawn this a little away because we need to explain something there. When this closes, aortic closes a fraction before the pulmonary. In normal people, first sound is followed by second sound. Second sound has two components, aortic and pulmonary. The first component is second sound is aortic component, second component is the second sound is pulmonary component. In aortic stenosis, first sound is normal because it is not affected by the dynamics. It is usually normal. There is a gap. Following the gap, there could be an abnormal sound coming here. This abnormal sound is injection clip. So the first abnormal sound that will come to the injection clip and it is followed by a one. This is the one of aortic stenosis. What is this murmur? It is a crescendo, decrescendo murmur. It is a diamond-shaped murmur. It is a crescendo, decrescendo, diamond-shaped ejection systolic, mid-systolic murmur. All names are correct. So what are the sequence of events? First sound, normal, ejection clip, followed by systolic murmur. There is a gap between the ejection clip and the murmur and the second. There is a gap. And this murmur is a diamond-shaped murmur or a crescendo decrescendo murmur. It is a mid-systolic murmur, the ejection systolic murmur. Why mid-systolic? It is in the middle of the systolic. Why ejection systolic? During the ejection phase of the systolic. Why diamond-shaped? The polar accord comes as diamond shape. Why crescendo decrescendo? When you auscultate, it increases and then decreases the loudness. This is followed by second sound, which has two components, aortic component and pulmonary component. Now let us say the patient has, this is a patient of aortic stenosis, free flowing with valves which are movable. So when the valve is pliable, the first sound is normal and second sound may be reduced. This component of the second sound may be reduced. Aortic component may be reduced. So the effect is S2 will be softer than the normal. S1 will be normal, S2 will be softer. Ejection clip is present and a diamond-shaped ejection systolic murmur is there. Suppose the patient has a calcification of the wall, fibrosis of the wall. This ejection clip disappears. So what is the role of ejection clip in aortic stenosis auscultation? It tells you that the walls are pliable, provide. What bypass is not done. It localizes the aortic disease to the valve. There are three possible types of aortic stenosis: valvular, supravalvular, subvalvular. So if there is a click in the valve, supra and subvalvular, there is no click. So click localizes the disease to the valve. Number two, it tells you that the valves are viable. Then comes this fluid stop. Now, if it is a more severe aortic stenosis, this A2, instead of being here, will move closer up here. So what happens to this now? It moves this side a single second. This third is a single second. There is no split, there is only 1 second. What was the first finding? A narrow split of second sound. What is the second patient having? A single second sound. What if it is even more severe, what will happen? Not only it moves closer, it may overshoot. I mean, there is a very interesting phenomenon. This comes later. So, it is on a reverse splitting. Instead of aortic being followed by pulmonary, pulmonary is followed by aortic. Reverse splitting or paradoxical splitting. So what are the behavior of the second sound? It may be soft. It may be split and the split is narrow. Why narrow? Because the valve is coming closer. It's coming closer to P2. Or it may be single. Or it may be reverse or paradoxical. So the most severe aortic stenosis is a paradoxical. Where do you get a paradoxical split? In severe aortic stenosis. Where else do you get a paradoxical splitting? In a left bundle branch block? Because it takes longer for the left ventricle to get, because left ventricle does not get depolarized through the left bundle as it should. Initially the right bundle will get depolarized through the muscle, it goes to the left ventricle. The left ventricle gets depolarized after a while, and therefore paradoxical second sound split can also be seen in LVDB. So these are the features of aortic stenosis. The normal wall of aortic area is about 3 square centimeters. If it is less than 2 to 1.2, height 1.2 to 1 is moderate, 1 to 0.8 is severe, and less than 0.75 is critical. So 3 is normal, 3 to 4, half of it 2 to 1.2 is mild, 1.2 to 1 is moderate, 1 to 0.8 is severe, below 0.75 is critical. So these reverse splitting is seen in this curve. This curve will be asymptomatic, this curve will be mildly symptomatic, this curve will be symptomatic and complicated, this curve will be critical. Not only symptomatic and complicated, he really can't walk, he can't work. So that's about the auscultatory phenomena in aortic stenosis. Also, if the patient has a left ventricular failure, he will have another sound that is SP. If he is in a left ventricular failure, he will have S3, and if it is long without any problem, it manages to live long, the left ventricle becomes very non-resilient, and when aorta contracts, non-resilient ventricle contracts in an effort to push the blood forward, it is not a resilient or a compliant ventricle, non-compliant ventricle. Give the rise to S4. So the sound S1, normal, S2, 4 possibilities. It could be soft, it could be narrow split, it could be single and soft, it could be reverse splitting. Or third sound may be present, indicating failure. Fourth sound may be present, indicating a non-resilient or non-compliant ventricle. Ejection field may be present, indicating a valvular level involvement and a pliable valve, diastolic valve, systolic valve, or damage. Understood? These are all the features of aortic stenosis. This is how you remember that. So, with this you have covered the entire auscultatory clinical features of aortic stenosis. Now, it is best heard where? This muscle is best heard in the aortic area, muscles, new aortic area, and conducted to the neck. murmur, again physics explanation, can be well heard in the mitral area. This is known as a Galley-Warden phenomenon. So where is the murmur best heard? Aortic area, out there. Where is it well conducted? Carotid. Third point, where is the murmur is well heard in the mitral area, known as the Galley-Warden phenomenon. Galley-Warden phenomenon. It can be mistaken for a mitral regurgitation. So what are the differences between mitral regurgitation and aortic stenosis? Aortic stenosis is a low volume pulse, angina, fatigue, and dyspnea, syncope, intermittent tachycardia. Mitral regurgitation doesn't have all that. It's a good volume pulse. It's a wide pulse pressure, ventricular enlargement. The apex is here, a heaving time, there it is hyperdynamic. It's angular but not able to localize. Here it is well localized. There is not well localized. Here the first sound is there. Here the first sound is muffled. Second sound may be very normal or muffled. Here the gap is there between the sound and the murmur. There is no gap in that. And ejection peak is there is no ejection peak. You have a second sound that is variable here. The second sound is muffled or normal. Third order sound is there in both situations. In aortic stenosis, third order sound indicates failure. In mitral regurgitation, third order sound necessarily does not indicate failure. It may be due to extra volume. Fourth order sound can be present in aortic stenosis, never present in mitral regurgitation. Never. So these are the differences between aortic and aortic because these two are closely resembling. And third condition is can mimic is PST, as I told you last. What is the investigation that you do with the test? What is the gestation showing? It may show a ventricular hypertrophy with a post-nordic dilatation of aorta. These are the two changes. Ventricular hypertrophy, post-nordic dilatation of aorta, calcification of aortic valve. These are the three changes. That's the pulmonary edema. Echo is useful to see the valve size, the valve health, presence of calcification, presence of fibrosis, presence of infected endocarditis, presence of regurgitation. Treatment is to give a valve replacement eventually, if whether the patient is symptomatic or not. If the patient has got a ejection fraction of below 55%, and if he has got any one of the other things like syncopal attack, angina, portal hypertension, any one of those, or if he is asymptomatic and has one of these like the low ejection fraction, gives the case for valve replacement. These are the things in aortic stenosis. Now we go to the next lesion, aortic infarction.